Okay, the discussion is at the end of the season. We continue with endovascular treatment of this arteriovenous malformation. Dr. Steve Mahudar. Dr. Shakir, I have one question. It's a technical question. What usually is your dilution with NBCA when you treat arteriovenous malformation?
This is a common question between.
Yes.
I think it's a very variable concentration of the glue is a very variable, I would say, both in terms of situations and even in the personal manner. At one point of time, if you have a particular selection of the concentration, and you do again a delayed microcatheter injection before you actively start that concentration, and you make a new concentration. So it all depends. The fundamental fact remains that, or the salient point, there is no actually the trick point here, but some of the salient points would be that what is the flow situation, whether it's high flow or a low flow. The position of the microcatheter tip, whether you have a wedge position or not, and what is the speed of the flow. So speed of flow, again, you can govern by yourself, that if you have a wedge position, if you inject slowly, it will move slowly into the nidus. And if you inject faster, it will go faster. So that gives you a good idea of how the glue will actually, and I think in the glue, what I have learned is that exactly I had the same question 20 years ago from Professor Balavanis, and till date I have not received any answer from him. And I think you have to develop your own answer. You are the best master for your selection of the concentration. So based on these salient, the points, but as a guideline, general one, I would say, if it is a low flow situation, we use something like about a 20% concentration. In a high flow situation, 80% or sometimes even 100% glue. And in between, if it is so, varies between 20 and 40%. So this is general, I would say, a rule that we follow.
Thank you.
Thank you.
We continue.
Thank you. Endovascular treatment of deep AVMs, combined transarterial transvenous approach. So it's pathology, deep AVM, it's a very big problem for open surgery, for radial surgery, and for endovascular surgery. I am going to present the result of the 66 consecutive patients with deep AVMs, minimum of 1 year follow-up, treated by means of combined arteriovenous approach between 2003 2004. Number of operations 145 and 2 operations per patient. Spessler-Martin grade. You can see it's very difficult type of malformation. 16% it's Spessler-Martin grade 5. 38% is 4, or 4. 35 is 3. Indication hemorrhage in 71%. Epilepsy 12%. Intractable headache 3%, and steel ischemia at 8%. Deep AVM is combined arteriovenous approach result, 12-year follow-up, 59% complete occlusion of malformation, 2 patients more than 90% occlusion, and 5 patients 60% occlusion. And you can see in completeness of embolization it 89%. Outcome in our clinic, there's 5 patients, is 7 and 6%, and the outcome scale 71 and 2%. It's a very good result. So why we have this good result? what is new? What is new in world with treatment AVM? And last 10 years, I know only one. It's Aruba study. I think this step, one step forward and two step return. In my clinic, we do operation with new liquid polyurethane-based liquid polymer. It's HELP. Combined arteriovenous approach, intraoperative arteriovenous pressure monitoring, and post-interventional controlled hypotension. You can see this new material. It's material with disappear of contrast material. After injection of this material in malformation nidus, contrast material disappear after 2-4 hours. With this material possible occluded of aneurysm, you can see material same with sphere and filament and coil. Approach of the intervention, transarterial, transvenous through the arterial route, the transarterial transvenous to catheter technique, and transvenous. Combined approach, several AVM considered inoperable until now by transarterial route. Ischemic complication can be reduced, ratio of total AVM embolization can be increased, number of sessions can be reduced. I would like to show this young patient, 90-year female, embolized in as a hospital. This patient arrived from Professor Valovanis after 2 procedures of embolization with success result. We admitted here acutely after the 4 hemorrhage, and its result after 2 procedures of embolization, this paramedian, very difficult AV malformation. It's 3D reconstruction. And you can see procedure of embolization AVM, catheterization of draining vein of the AVM through the Rosenthal vein. And result unbelievable. It's only 1 procedure, and you can see absolutely disappear of AV malformation. Transarterial transvenous approach and pressure monitoring. It's very important, but only transvenous approach very dangerous for rupture malformation. You can see 1 catheter transarterial we put in malformation nidus, and the next sinus sagittalis superior and draining vein. Pressure, arterial and venous, 67 hydrargon millimeter. You can see several shunt effect. After partial occlusion of arterial fistulosus part of malformation, pressure in venous system decrease, and you can see 21 hydrargon millimeter. Pressure measurement during catheterization of artery and vein. And pressure monitoring after partial transarterial embolization, nidal pressure gradient dropped to 1/3. It's ideal situation for transvenous embolization of AVM. And I would like to show very interesting patient. Is 48-year female, severe headache for 5 years. It's a vertebral angiography, and you can see a big malformation with shunt, direct shunt, arterial venous shunt. And carotid angiography, and you can see many feeder AVM. For catheterization, it's impossible, but super selective catheterization, all feeder in this malformation. So combined arteriovenous approach. The first step is disjunction of fistula by means of GDC and HELP, transarterially. Second step, transvenous catheterization of draining vein. The next step, transarterial catheterization of posterior cerebral artery feeder. 4 steps, transarterial embolization of AVM nidus by means of liquid polymer. and transvenous occlusion of the draining vein of AVM by means of GDC and liquid polymer. And you can see result, vertebral angiography 4 days after the last step. Malformation absolutely disappear. Carotid angiography 4 days later, and you can see normalization of flow and disappear of malformation. Disappear, but without any embolization of the feeder. Normalization of pathological vessels, normalization of autoregulation, without any embolization of feeder. So we don't close we don't close malformation from middle cerebral artery. And carotid angiography, arterial, capillary, and venous phase. 15-year boy with Glasgow Coma Scale 7 with intraventricular and intracerebral hemorrhage for 40 days ventilated and ventricular drainage. Feeders from anterior choroidal and lenticulosternal arteries. This is very dangerous for embolization malformation and technically impossible. Feeders from posterior choroidal, lateral, and medial artery. You can see procedure, catheterization, and coil and liquid polymer retrograde occlusion of draining vein of malformation. It's procedure and angiography after embolization of the nidus via one lenticulostriate artery and the thalamostriate vein by means of coil and liquid polymer. Remnants of nidus still filling and stasis in draining vein. It's very dangerous situation after transvenous embolization for rupture, for bleeding. And you can see result, and I close only one feeder of transarterially, and you can see malformation not work. It's magnification, and we don't do occlusion of AVM. You can see normalization of microcirculation. It's pre- and post-operative picture. And result of vertebrobasilar system without embolization of any feeder. 23-year female with subarachnoid hemorrhage. You can see diffuse malformation from arteria pericalosa, and this is left side. This is non-standard projection. You can see procedure of catheterization of sinus sagittalis inferior and venal thalamus striata. And you can see result of. So for me, it's unbelievable. It's impossible. Normalization of malformation, it's possible. This is very small micro AVM. It's not simple for embolization. 30-year-old maid presented with serious intracerebral hemorrhage. You can see this small malformation, and you can see super selective angiography demonstrated minimum six microfeeder from the middle cerebral artery. It is impossible to catheterization these small feeders. You can see transvenous approach. I put microcatheter in nidus of AVM and close malformation transvenosely, retrograde. And you can see result after embolization. The next patient has big malformation. It's deep, frontal, big malformation. 27-year-old female with intractable epilepsy. Previously, she was embolized 7 times on another hospital. The AVM is supplied by means many feeders. It's magnification, dural part of malformation. Yes, and as patient have thrombose of sinus rectus. It's very dangerous, but after occlusion of draining vein, very dangerous for rupture of malformation. Catheterization transarterial and transvenosely, and you can see result preoperative and unbelievable post-operative result. And this not resection of brain. Complication, you can see this big malformation. So we have complication after occlusion, partial occlusion of AVM, you can see bleeding. We know 3 problems with bleeding, 3 causes. The first is perforation with guide wire. Second, this quick change of hemodynamic. And third, it's we push liquid polymer in possible rupture aneurysm during injection of liquid polymer. This is happy end. You can see not open malformation. You can see 3 months later, this malformation is disappear and very good result. But what do with hemorrhage? Following combined transarterial transvenous treatment of brain AVM to prevent perioperative bleeding, we applied a new technique, artificial carotideo-femoral arteriovenous shunt. What is this? Previously, we used deep narcosis and artificial system hypotension. This new technique uses local hypotension and the patient can be weakened. Since this is new technique, we applied it in 5 patients so far and had no perioperative bleeding yet. The shunt caused no problem to the patient. We hope this technique can be an effective way for preoperative bleeding prevention in the future. After open of shunt, you can see pressure go down in 50% in carotid pressure. And you can see the next patient with aneurysm, with big malformation and deep malformation, venous terrible system, and after treatment, you can see not only disappear of malformation, disappear in aneurysm. It's spontaneous. And I would like to show the last patient, these children, 2 weeks, in my clinic with asystolia. This patient, young baby, have big vein of Galen malformation. You can see right carotid angiography, left, and vertebral basilar system. Hypertrophy of myocardium, and procedure of embolization with coil and help. And you can see result after only 1 procedure of embolization. And this woman 1 year later, and 2014. So conclusion, to occlude only the vein increases the possibility of intracranial bleeding. The combined transarterial transvenous approach made it possible to complete occluded the malformation. The combined transarterial transvenous technique decreases of complication rate. It is not required to embolize all the feeder arteries transarterial. The blood flow in the malformation stops after the blockage only the pathological vein and the fistulous part of well. So arteriovenous malformation is not arteriovenous, it's capillary venous pathology, and target for occlusion, it's venous system. The nidus of the malformation can regenerate and get back to normal after the occlusion of the pathological arterial and vein. So vessel originally visualized needle anomalies mustn't be always occluded, resected, or irradiated because they are capable of regeneration and normalization. Thank you.
Thank you very much, Professor Hudak. We're going to make a slight change to the program, and coming up next is going to be Professor Lopez with the endovascular approach of complex AVMs when territories or areas represents a challenge embolization options. Discussion will be held after every speaker has presented.
Siguiente. Siguiente. Esa. Ahí. Good morning. Okay, thank you very much, Dr. Hussain and Dr. Hudak. Fantastic presentation. This is another point of view or another philosophy to treat the complex territory of a brain AVM, when the territories of neither represent a challenger for embolization options. Classical, you know very well the angioarchitecture of the AVM. Classical is the fistula, aneurysma, ectasia, venous. But now, for me, for our equipe, the most important is the analysis of anatomical territories and collateral circulation. In the beginning, when you study one AVM, you need to know where is the local anatomical localization of the nidus. This is a frontal AVM, cortico-subcortical, but the feeder, the principal feeder, or the main feeder is only the middle cerebral artery. The feeder comes from the anterior cerebral artery is the collateral circulation. You know, in this part of AVM, you are the lenticulo-striatic artery 2. And when do you think is the best or most important to treat it? Is to treat it the total AVM, but the choice of the vessel to attack the nidus is not the middle cerebral artery, maybe it's the anterior cerebral artery. Next, this is lateral view. Next, this is initial, in the left is the initial angiogram, first embolization, 6 vials of onyx, second embolization, 4, third embolization, 8 onyx in the anterior cerebral artery. Next, this is the control post embolization, total occlude from this AVM only with onyx. Why I prefer the onyx? Because you need a resection of the nidus after embolization. It's not easy to remove for the surgery when you put the onyx, when you put the glue. It's the only difference. This is final control. This is, no, para atrás. This is anterior. Anterior. Siguiente. This is this, another malformation, but it's not the middle cerebral artery, it's anterior cerebral territory. Every time I put the functional angiomagnetic resonance, I think it's important to know where you are the supraterritories, functional supraterritories. It's similar, you are the next, you are the AVM, anterior cerebral artery, you are the lenticulostriatal artery, and the collateral circulation, leptomeningeal circulation, is the middle cerebral artery. Next, in lateral view. Next, one session, second session. Next, it's possible to put the onyx. Next, and it is a final result, only 2 sessions of embolization, and the rest is cortical arrest. Is possible to treat it by surgery. Next. The second question is, why do you treat it, when do you treat it, the patient is, AVM is ruptured in acute phase? Classical, you need wait, but in my opinion, it's important to treat it in acute phase. The only problem is that you need a control, angiographic control after embolization 1 week or 2 weeks or 1 month. Next, this is acute phase with hematoma. Next, this is AVM. You know now you are the intranidal aneurysma. Next, AP view. This is the catheterism. And this is the only 1 session total occlude of the AVM. This is the control. Next, without deficit, visual deficit. This is another malformation more difficult. It's in the fingulo, corpulo calloso, and fingulo is the normal. This is the arteria in passage. It's not dilated arteria. It's only very difficult to need. This patient is bleeding, but in the first step, I catheterize only the feeder of the pericallosal artery. You know now the hematoma and the intra-aneurysmatic nidus. I put the onyx in first session. Next, 2 weeks later, I treated this part of malformation not by the way of the anterior cerebral artery, but only by collateral circulation for frontovasal artery. You know, like in lateral view, you put the onyx, is the onyx going very far to the nidus. It's possible to treat the AVM. This is another complex. This is the control. Next, another question is the territories, lenticulo-striatal territories. The glue is better, but is better to the onyx. The problem is very difficult to resect after surgery. But the onyx is most easy going to the nidus, but the problem is that you are the reflux, retrograde reflux on the onyx, and you don't know this material when stop. Next. This is one AVM, lenticulostriate AVM, very complex, left side and right side. Next. In lateral view. Next. Only a 4 session of embolization. This is the catheterism of every pedicule of lenticulostriatal artery. Next. And this is the cast of the onyx. And this is the final control. This rest of AVM is treated by radiosurgery. Normally, I don't treat the patient with radiosurgery, only in in the deep territories or functional territory. Next. This is another example, very complex. You are AVM. It's possible to catheterize the lenticular artery with technique balloon, assisted balloon. Next. And this position, I decide to treat it with onyx. Normally, I treat it with glue, but in this case, I treat it with onyx. You have the cast of onyx in the deep part of AVM. Next. But the patient have a deficit because you are the reflux of the onyx in the initial part of lenticular artery. Next. Next. You know this is the cast, and this is, in our opinion, the lesion of the capsula interna, because it's impossible to see in the technique the reflux of the onyx. In this position, normally I prefer to use the NVCA. Next. Another question is when you have the direct fistula, the classic is to treat it with NVCA, but it's possible to use the onyx with a technique of Beaver technique. It's similar of pressure cook of René Chapeau, but my name is the Castor technique. It's different. Next. You are here one big AVM, a middle cerebral artery. You have the high flow fistula. This is important because you know you are open, still open the leptocortical, leptomeningeal anastomosis in the anterior cerebral artery and the posterior cerebral artery. Next, this is the fistula, high flow fistula. And then in lateral view, I put before one catheter with coils in the feeder. This coils is the fiber coils. It's not the standard coils, it's the Nexus fiber coils, because this is more thrombogenic, and you put distal part, you put one second catheter. It's possible to use the onyx, and it's possible to injection slowly in every part of the fistula or every part of the nidus, onyx without glue. Next. This is the 3 fistula totally closed with the onyx and the technique of different technique. Next. The second or another question is the big AVM 4-5 Spatter grade. The most important is treating the patient in multiple sessions, because the problem is the breakthrough. The breakthrough sometimes is you have the rebleeding of AV. Next. This is one patient, Spetteler Martin 5, bigger malformation, a lenticular striatus. Next. Next. In lateral view. Next. Next. This is collateral circulation with the cerebral anterior artery. I treated a multiple session of embolization, about 4 sessions. Next. 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 After 3 sessions, this is the control, and the patient going to surgery. This patient going to surgery in this hospital. Next. The first surgery, this is the control post-operative angio control. This is the only rest in the deep part of a small malformation, and the patient 1 week later, next, stop. 1 week later, this is the control MR. You only know, only the deep part of the AVM, and the neurosurgeon discussed with me, I want to treat this part, why not stop? Because maybe you are a problem of the autoregulation. No, I think it's better now to go, because I have the way to attack the rest, okay? The neurosurgeon going, and the second surgery, intraoperative massive bleeding. This is the phenomenon of breakthrough. Next. This is the control angio. 1 month later, you are the problem, morphological problem in the vessel. You are the vessel is dysplastic. The name is Stupp effect. It's not a spasm. Is the the autoregulation is bad. Next. And 1 month later, total removal of the AVM, a second rebleeding. Okay, this is final angio. 2 months later, total cure de malformation, the autoregulation is normal. Next. This is the theory of Professor Pertusset in Paris when I worked in the last century. This is the problem to the resection of the AVM. Next is step by step because you are alteration of the autoregulation. Next. This is the paper of the normal perfusion pressure through. I published in this hospital one paper in the last 2 years. Normal perfusion pressure phenomenon. It exists. It exists. It's not theory. It's real in the big malformation. Next. Leptomeningeal access of embolization is another possibility. Is in the complex AVM, the leptomeningeal feeder, maybe you know this is impossible to go to the nidus. No, it's possible going to the nidus, and maybe it's better to go to the nidus to attack the AVM. Next. This is a malformation, big malformation in lateral view. Next. I embolization for normal arterial feeder of pericalosa and callosa marginalis. And this is, stop here, this is the collateral circulation of posterior cerebral artery, posterior pericallosa. Because I have the collateral circulation, I attack the nidus, only this feeder, 2 feeders. It's impossible to know, it's not possible to go to the nidus. No, it's not true. See, going, the on is going. Next. Look this, subtotal occlusion of AVM only with the collateral circulation. Next. Yeah, this is the final control. Next. Yeah, this is the final control after this embolization. Another example, the patient is here, is my friend. Is a patient is treated 15 years ago by myself in another city. It's a big malformation. This is a left side, right side. Next. Next. It's treated by arterial approach. It's treated by radiosurgery. And finally, the patient developed a progressive neurological deficit. Next. After 3 embolization, total occlusion of the anterior cerebral territory, but the rest of, no, anterior, but the rest is the collateral circulation. Collateral circulation, leptomeningeal circulation, the middle cerebral artery. Next. Next. This is angio 3D. Next. In lateral view, I'm going with a microcatheter. Next. 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 I'm going to navigate to this point. Next. In lateral view and AP view, you have only the small contrast in the AVM. I decide to put 8 vials or 10 vials of onyx. Next. This is before embolization in leptomeningeal is only with the anterior artery. Next, this is after leptomeningeal embolization, only with this small catheterism. Next. This is control, final control. Next. 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 And going to surgery. Next. Next. And this is total remove of AVM, total cure. The patient have only a deficit, arm deficit, and this is well. Next. This is the control. Next is the bigger AVM. This is the paper developed. It's better to use the onyx in AVM, but to the blue. I think maybe the material of Professor Hudak, I think is fantastic. I don't know, maybe tomorrow or for the next year you come with the material starting. Next. And finally, Another comment is why not to attack the AVM with the dural approach? Next. This is a patient treated 20 years ago with a neurosurgery. I have a big AVM, I have aneurysm, I have very complex. He comes to the hospital with status epileptic, very difficult to control. Next. This is AVM. AP view, you are the collateral circulation of cerebral anterior artery and arterial feeder of the middle cerebral artery. Next. A lateral view. Ponme el anterior. You are the middle meningeal artery origin of the ophthalmic artery going to the nidus. Next. And this is the temporal superficial artery. Only with this pedicle. Next. Next. I treated initial by cerebral anterior or middle cerebral artery with classical technique with onyx or glue. Next. 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 And the second procedure, I use the temporal superficial artery. Next. AP view. Next. Next. And this is control, final control. Next. Only with embolization, without surgery, and final control, I treated the patient with temporal superficial artery. Next. And finally, embolization by venous approach is very elegant, is very interesting, but is very difficult. It's not possible every time. This is a young patient, have a hematoma, we remove the hematoma, and in the deep part of hematoma, you have a small malformation. Next. This is lateral view. You see the nidus, you see the small vein. Next. It's possible to attack this nidus with venous approach, AP view, lateral view. Next. This is the control after embolization. I think it's okay. Next. Next. But rest, I have a small rest of the deep part in the interior cerebral vein. Next. Second catheterism. Next. A total occluded by a venous approach. Next. This is the control angio, a CT scanner. A second example of the venous. It's possible to treat it. Next. I put the technique of balloon to navigate. It's very difficult to navigate in the sometimes to go into the nidus. Assisted balloon is sometimes you need assisted balloon. Next. Next. This is catheterism. This is the onyx, reflux, and total occlusion of the AVM, by venous approach. I agree with Professor Hudak. Maybe the combined approach, arterial and venous, is very interesting to stop the evolution of malformation. Finally, commentaries, anatomical, cortical, or deep territories is important to know. In acute phase, it's possible to treat it. I think I need to treat it every malformation in acute phase. It's possible to treat it, the big AVM, 4 or 5 spedal. I have a paper, I treated 40 patients with 4 or 5 spedal case, a total cure after embolization or complementary surgery. The collateral leptomeningeal or external carotid artery is shown the good way to treat the AVM, and the venous approach is possible to complete or to remove the final part of the AVM. Next. Why prefer, in my opinion, why is better for me the onyx? Now, maybe tomorrow I decide the material of PEX in Hungary, because it's more easy to surgical resection. You have less session of embolization. The only problem is you are conservative. It's very important not treating the the goal is not treat the AVM in one session, is the step by step. And the venous approach, I repeat, I think is a good idea. Thank you very much.
Thank you very much, Professor Lopez-Igual. We will now resume the normal programming with Professor Ricardo Janel, who's going to talk to us about microsurgery of DABF after failed embolization. We welcome you upstage.
Buenos días. Más una vez, ayer cuando yo agradecí a Luis, no estaba acá, so nuevamente Luis, muchas gracias por invitarme. Es un placer estar con usted acá en Madrid, en Viva Madrid, es muy bellísima ciudad, mi primera vez en Madrid con amigos, so muchas gracias. I'm going to bother you a little bit, and I know this is a heavily endovascular, interventional radiology, interventional neurology community. So I'm just gonna show you a little bit, and Juha Hirschniem was gonna show this yesterday. I think for sake of time, he did not show that. I just wanna show you that there are still some circumstances that surgery can be helpful, and Dr. Serkuje would disagree with that. He said, no, you don't need surgery for anything. Even though he's a dear friend, it's okay to disagree. This is my new house, and again, mi casa su casa, for anybody that wants to visit us. I'm not going to bother you with things that you know already. Dural AV fistulas can happen in any place that you are related to the sinus, much more common on the transverse sigmoid, followed by cavernous, but it can happen anywhere. We know, and that's one thing we teach the residents and the fellows, it's all about the corticovenous drainage. If you're dealing with a lesion that has corticovenous drainage, it's a very bad disease. With the new St. Louis data by Zipfo and others, it seems that if these patients are symptomatic, the natural history is even worse, or replicates what Castaigne and others showed in the past. But if you take the patients that have corticovenous drainage, they are asymptomatic, no intracranial hypertension, no hemorrhage, the natural history is more benign. So it's down to 8% from a 40%. There's the classic number that we all were taught to remember. Prime modality is endovascular. There's no discussion. When in AVM, especially after Aruba, endovascular took a big hit in dural AV fistulas, there's no question. This is an endovascular problem. And you go for a different approach if you cannot treat with endovascular. I think we have all these agents, and I think we can easily paraphrase Franklin that said that beers living proof that God loves us. We can say the same thing about onyx. I think it helped us tremendously to treat these lesions, and with the scepter balloon now and all these catheters and distal access catheter, we can cure many of these lesions, most of these lesions, by endovascular, no question. But I think microsurgery still plays a role in two conditions. When embolization can be too high risk, especially with a transarterial approach, And I've been through different phases in my career, and I always like to put here like this a typical anterior cranial fossa that I'm going to show you here. The video in a second. If you have to go through the ophthalmic artery to embolize a fistula, you may consider not doing that for safety reasons. And I had 2 patients over 10 years that lost vision because of my bad judgment, where with a simple small craniotomy I could have cured this patient without exposing the patient eye to that risk. And this role is getting smaller because now with better catheters, better distal access catheters, we can get in a further distal through a transvenous approach and maybe avoid this more aggressive treatment with surgery. And if you fail embolization, and we have a series of patients that have embolized, you look at the X-ray, that typical picture that you see, glue, onyx, and coils everywhere, and the fistula is still there and doing very well, alive, the fistula. So for those, I think microsurgery does play a role. Different than AVM, and Luis showed beautiful cases here of AVM treatment combining endovascular and surgery, where the vein is the enemy. You got to preserve the vein all the way to the end. You got to save that. In AV fistula is exactly the opposite. If you know you characterize this as an AV fistula, if you kill the vein, the problem is gone, and you don't have to worry much about all the arterial feeders. God bless you if you call it wrong, a fistula. If you call an AVM a fistula and you sacrifice the vein as the first move of a surgery, that's a disaster. But if you know this is a fistula, you take care of the vein, you don't have to bother about the arterial fistula. Just shut down the outflow and that lesion will die. And that's what we do with surgery. So surgery, it can seem pretty complex when you open and see all those dilated veins. Actually, it's pretty simple. You just have to disconnect a vein, and very often it's a simple draining vein that you have to identify. So this is a patient we're talking about a second ago. This guy presents with a hemorrhage, has a typical anterior cranial fossa dural AV fistula. Probably today I would have tried to go transvenous to get to the vein to this point and just embolize retrograde. Back then, I just happened to have a guy, I had a series of 5 cases that I went to the ophthalmic, I'm feeling brave, this is awesome. And then patient next, I lost vision in eye. I was far distal from the central retinal artery with a nice blush, embolized, patient thrombosed the whole ophthalmic artery and lost vision on that eye. So I think you have to think about these things before you decide what you do. And here you're doing surgery, a small anterior craniotomy. You just follow the Fox, and you're going to find this vein, and all you do is disconnect that vein. You don't have to worry about where are the arterial feeders. You find the vein, all you have to do is coagulate or clip that vein, and here is just dissecting that. So it's a pretty simple operation. And here you see the clip coming. And that's the post-op. External, internal injection, the whole fistula is obliterated. Here you see another case. This gentleman had been struggling, go to a bunch of different places. He got gamma knife for trigeminal neuralgia, but the neurosurgeon that saw him before the gamma knife failed to recognize that he had a big offending vessel right into the trigeminal nerve. So he went to see an interventional radiologist that decided to do an angiogram to see what was going on, because there was a dilated vessel and it was found to have a dural AV fistula fed by Bernasconi Cassinari that would end up being treated to a transvenous approach with occlusion of the vein. And bear with me because some of the videos are not playing on the main, so I'm gonna have to go back and forth between the PowerPoint. And this is a 3D video recording, so you're gonna have 2 images of the same. So this is a retrosigmoid 3-centimeter craniotomy on the posterior fossa with no retraction, lumbar drain in place, so the cerebellum will drop. The patient's on his side, and we're coming on the top of the cerebellum on the left side, and you see here some telfa covering the cerebellum here, and I'm going to play this for you. You're going to see the coil mass into the vein, You see the coil mass right here under my scissor. I'm just decompressing the trigeminal nerve. So I'm treating his trigeminal neuralgia and the fistula at the same time. Here you see the coils into the vein, and why this failed, there's another vein right here. So the main draining vein was there and was splitting in two components. And one got occluded by the coil, but it didn't go deep enough into the foot of the vein to shut that down, and that's why the fistula survived. So from that, the surgery becomes very simple. It's just a matter of decompressing the nerve, and we put some Teflon into that to separate the nerve from the offending vein, and we disconnect the fistula. And here you see the post-op with no residual fistula. And you can keep going through situations that look more complex, like for example, this guy, the example I was telling you, that had multiple failed attempts for endovascular treatment in many different hospitals. And this is a patient that got multiple embolizations again, and you're gonna see here, this is an angiogram done on the outside, and you see all these nice feeders that probably many of us would say would be able to get that fistula. He failed that, and you see here on his post-op picture all types of material, coils, and some pedicular injections of onyx. You see all the work that was tried before, and probably poor attempts of endovascular, to be completely honest. But this gentleman, when he came to us, said, I don't want to try this anymore. And all the feeders that were nice to be embolized and probably could have been embolized successfully were shut down. So the doors were closed, and this video is kind of a retro video, because somehow when I went from Windows to Apple, this only video lost color. Nobody can explain that. But you see, this is a supracerebellar approach. This is the cerebellar tent right there. This is the vermis, especially in a sitting position. So the brain just falls, and you find that big vein right there. All you have to do is shut down that vein. You don't have to worry about all these feeders coming from both externals, both Bernasconi, Casinari. Nothing matters. What matters is the vein. And you see here a beautiful ICG injection, and colored matters less on this one here. So I think it's nice for you to see that. You see here that vein, nice and filling with the ICG injection before, and here after the clipping is in place, you see that. This is reminiscence of the IC green for the first injection. The injection of fluorescein on IV, and you can filter that into the microscope and see this beautiful picture into the light into the screen of the microscope, and you see the clips right there and the fistula disconnected. So on the pre-op, you saw all those feeders coming from multiple different branches. In the post-op, single two clips, don't bother about the feeders, you just shut down the vein and the whole fistula goes away on the immediate post-op images. There's another case that seems very complex. This young guy presents to us with progressive paraparesis, quadriparesis, myelopathic, and you see here why. All this dilated venous complex from the drainage pattern and increased venous pressure into his system. And you see here a fistula from these very tortuous branches of the vertebral artery. We did embolize and were able to disconnect some of the artery, but we could not penetrate enough to disconnect the vein. And here you see why he has all that change on his upper cervical spine. You see the draining pattern here of this fistula. So when you go to his surgery, because we failed embolization, surgery can seem very complex. So this is a far lateral approach. We are operating on the patient's left side. So you see here our opening, this is the cerebellum there, and we're opening the arachnoid. And it's very intimidating when you're not familiar with this, when you see all these dilated vessels there, what am I dealing with? You got to remember that you just need to find the foot of the vein. That's what the key is. And you see all these dilated arterial feeders here that you don't have to bother about. You got to make sure you're identifying the vertebral artery because you don't want to clip the wrong vessel. But here you see here the icy green. And here you see all we're doing is clipping the foot of the vein right there. And all these dilated vessels will go away. And here you see now the icy green again. So you see that the pica is filling nicely here, but you see that the vein here is just not moving at all. So it's a simple disconnection of a complex, what could be thought to be a complex problem, just a simple clip on that vein. Solve the problem. We still believe that for simple spinal AV fistulas that fail approach by endovascular, I think surgery is a very good option. This patient has a potential of two feeders. There was a questionable T6 and a clear T5. This patient had a perforation issue and attempting embolizing this fistula, and the fistula remain alive. And here is the decision was made to take him to surgery because of the problem and fail of the endovascular attempt. And the fistula remain alive. And again, it seems pretty complex, and brilliant neurosurgeons, giant Turkish Yazırgil used to stripe all these veins in the 60s to treat AV fistula because of our lack of understanding of the disease. Now we know that the pathology is all here. That's the simple connection, one simple connection of this type 1 dural AV fistula of the spine. All you need to do is disconnect that, and that's what we do with surgery, pretty simple. Coagulate, cut. And here you see the disconnection. I'll show you that and I'll stop. Send that for pathology. And this is the disconnection. You're going to see this laminar flow being reestablished and all those veins that will go away over time. And you see here now that you saw that brisk feeling that is not there anymore. The veins still feel from the normal, but you see the flow is much, much, much slower. And that will involute and go back to be normal vein. So that's the post-op angio showing the complete disconnection. The goal here is just to illustrate that no question that endovascular is primary, but I thought it would be interesting for this crew to see what AV fistula surgery is. And if you have somebody that truly understands what the surgery is, it can be pretty simple, a surgical solution if the endovascular that is first line fails or is judged to be high risk for these patients. And with that, I'll stop. I think if we have any questions, we can discuss. Novamente, muchas gracias, Luis.
Thank you, doctor. We're going to continue next. The next presentation is Dr. Matsumoto, endovascular treatment of rupture brainstem arteriovenous malformation.
Okay. I'm honored to have an opportunity to give my talk. I would like to talk about endovascular treatment of ruptured brainstem AVMs. This is my theory. First, let me start by introducing Kona Hospital, which is located in Sendai. Kona Hospital have started by Jiro Suzuki, who is well known for Moyamoya disease and so on, and Professor Akira, who was first director of our department. He is active as musician now and to help the people who damaged by big earthquake and tsunami. This is a famous ranking book in Japan. This book introduced Kona Hospital as #1 in the neuroendovascular field. Let's move to today's main topic. Treatment of ruptured brainstem AVMs is a challenging area, obviously. First case is 35 years old man. He suffered from sudden onset of ataxia. CT scan showed the brainstem hemorrhage, and MRI shows pontine AVM. We performed the angiogram. But it is difficult to recognize the AVM because the AVM is so small, and in such cases, to understand angiographic angioarchitecture is important. I will show you the movie. Our GE's workstation have very unique feature. If you deposit the cursor on 3D image, now it's on the feeder, the cursor follows the both of 3D and axial images simultaneously. It helps a lot to understand angioarchitecture in details. Change the angle and move the cursor. You can see here the nidus. We use this technique always. And after NBC injection, AVM disappeared angiographically. Post-clinical outcome is good, and the patient has no neurological deficit. You can see the nice NBC cast. I love my dog and my family. Next case is 56 years old man. He suffered from sudden onset of severe headache. CT scan shows subarachnoid hemorrhage and brainstem hemorrhage. Neurological findings are grade 4 and left hemiplegia and right cranial nerve palsy. The patient was transferred to our hospital 3 weeks after the onset. MRI shows right pontine AVM. The angiogram showed the AVM. Feeder is single, a long circumferential artery branching from basilar artery. Draining route was a single, and petrosal vein into superior petrosal sinus. Another angle. We can see the aneurysm, which were considered site of rupture. And this AVM has single feeder and single drainage system. So, our treatment strategy I took, TAE using Onyx to embolize feeder from feeder to drainer to complete obliteration. This is the microangiography. I inserted microcatheter just proximal site of the nidus. Onyx penetrate into the nidus. Step by step, any without reflux. Finally, Onyx penetrates through the nidus. Injection time 11 minutes 40 seconds. And this is the final cast. Key to complete obliteration is Onyx feeding from feeder to drainer, as you know. Final angiogram. AVM has gone. SPS was preserved as normal venous drainage route. Next. Arab fishing soul. You can see big flatfish and a river salmon. Next case is 21 years old man. He suffered from sudden consciousness disturbance and left hemiplegia. CT scan shows brainstem hemorrhage and MRI shows mesencephalic AVM. T2-weighted image shows mesencephalic AVM and perifocal edema around the nidus. This angiogram shows the AVM. We know the feeder is 3. So this is the DSA image of feeder number 1 and microangiogram. The microcatheter needs to be advanced to more distal. Finally, I succeeded to insert just the tip of microcatheter into the proper feeder. Compared to the previous DSA, the catheter was advanced just by the length of one piece of marker. As you can see, feeder number 1 and inferior part of nidus have disappeared, and also I succeeded to keep the normal artery. Next, the marathon catheter was advanced into feeder number 2. Microangiogram showed this artery was proper feeder to AVM. The proper feeder was embolized by Onyx 18. You can see the nice onyx cast from feeder to nidus. The feeder number 2 and the superior part of nidus have disappeared. Finally, the marathon catheter was inserted into feeder number 3. After the embolization, DSA demonstrating the complete obliteration of the AVM. On rotational angiography, we can see the complete obliteration of the AVM. And there is no infarction on the diffuse weighted image 4 days after the treatment. And the T2 weighted image dramatically improved after treatment. I'm very lucky, so the patient has no neurological deficit. And 6 months follow-up angiogram shows AVM has gone angiographically. I love football, so. Next case is 36-year-old woman. She suffered from sudden headache and right hand paralysis. Right hand paralysis is a severe problem because she's a piano player. CT scan shows subarachnoid hemorrhage and brainstem hemorrhage. And this MRI shows pontine AVM. The angiogram shows the AVM. And left side is volume rendering image, and right side is MIP image. Here is paramedian arteries branching from basilar artery. Here, we can't use. And MIP image shows intramedullary AVM and intranidal aneurysm. And the drainer is here and single. The intranidal aneurysm was considered point of rupture. So, treatment strategy I took. First, TAE to decrease the flow to the intranidal aneurysm for preventing early rebleeding. Second, gamma knife therapy to achieve complete obliteration on pontine AVM. This is the DSA of working on all. I inserted the microcatheter into the feeder branching from basilar artery, and right is microangiography. I injected 20% NBCA via this feeder without any reflux. Now it's pushing. Still pushing. Without any reflux. Now pushing. For the microcatheter. You can see the nice cast of an NVCA without any reflux. We need 55 seconds. And intranidal aneurysm has gone, but nidus still remained. You can see. Next. So we added gamma knife therapy as planned. Clinical course is good. 2 years follow-up after treatment. No bleeding. Follow-up angiography shows complete obliteration of AVM. And very happy, so she is active as a piano player now. Last case. I will show you the memorable case in 2007. We used flat panel, single plane DSA machine. The case is 59 years old man. He's a doctor in private clinic. Chief complaint, severe headache, and present illness is sudden onset severe headache. But she came to my hospital because the neurological checkup 5 days after the onset because he was so busy to open his own clinic. So we can see the subarachnoid hemorrhage, grade 1. This MRI shows the abnormal vessels on the left side of the pons. And we can, bloody spinal fluid was confirmed by cecal puncture. Angiogram shows cerebral pontic AVM and feeder aneurysm. This is a working angle. Angiogram shows feeder is long circumferential artery branching from vaginal artery, and this feeder has a feeder aneurysm. Our diagnosis. The MRI shows the subarachnoid hemorrhage located only around the prepontine cistern and no hemorrhage around the nidus, which might suggest that the ruptured site was the feeder aneurysm, not the nidus. How do we treat it? Aneurysm is ruptured and AVM unruptured. Strategy I took in my youth: embolize unruptured AVM only. We decided to embolize the nidus itself because, first, the hemodynamic stress of the aneurysm would decrease after the nidus embolization, which might prevent the rebleeding from the ruptured aneurysm. Second, the aneurysm located on the high flow feeder, so therefore, it would have a higher chance of recanalization after aneurysmal coil embolization. Please imagine the rest. It was my young blood that drove me to do it. I inserted the microcatheter into the perforator to reach the AVM. And of course, through the ruptured aneurysm. This is the microangiography. I inserted the balloon catheter in preparation for the rupture. And the microcatheter tip is just before the nidus, yes. And I injected the 30% NVCA. See? Now pull back. So just after the angiogram, aneurysm has gone. Just after AVM embolization, the aneurysm has gone. Honestly speaking, I was surprised to see the angiogram. Next image, just after the embolization. And next, we can see the fluid aneurysm, but AVM still remained. And MRI shows a small infarction in the left side of pons. Of course, fortunately, this is asymptomatic. We can see the residual AVM was treated with gamma knife therapy 9 weeks after the treatment. And this is the angiogram, follow-up angiogram, shows the complete obliteration of the nidus. And clinical outcome is very good. 9 years after treatment, no bleeding, and we can confirm complete obliteration of AVM. That's right. My conclusion, we reported some cases of ruptured brainstem AVM successfully treated with TAE using NVCA or Onyx. Treatment strategy and accurate anatomic information and technique are very important to treat ruptured brainstem AVM safely and effectively. Thank you very much.
Thank you very much, Professor Matsumoto, for your presentation. We will now take questions for any of the speakers in this discussion group.
Okay.
Yes.
Professor Yuda, please comment about my result and the indication for your CABA.
Not all cases for transvenous approach, and I think very important is culture of angiography, culture of procedure, embolization, and understanding venous system. But now we don't, so not now, I think 10 years ago, we don't understand the good malformation with pathology and venous draining system. I think indication for transvenous approach, for combined approach, it's impossible catheterization of microfeeder, it's deep malformation, it's multisectoral malformation, so I think it's indication.
Thank you very much.
Thank you very much, Professor Matsumoto. One question, some malformation is not the brainstem malformation, it's superficial malformation, similar to the superficial or perimedular malformation. And my question is, would you prefer to use Onyx or you prefer to use NVCA? And the final comment, when you treated the patient with the middle cerebellar artery, you have the lesion hypoacusia kyphosis?
I think I can use both. I love to use both because NVC has a strong point and Onyx has also have a strong point. We should understand the difference of each.
Another comment. Every malformation in the spinal cord AVM,
Spinal cord
or in lenticulostriate AVM, or in brainstem AVM, every time, in my opinion, it's a paper I present in Valdicet, but it's impossible to go. Every time you are the intra-aneurysmatic nidus, and the radiosurgery, in my opinion, is very dangerous because you are a high risk of bleeding.
Yeah. Concerning about the spinal cord AVM and the perimedial AVM, our strategy is open surgery is good, so we don't have the case. That's my answer.
I have a question for Dr. Hudak. We refer to the pressure between both compartments, arterial and venous compartment. You perform when you perform embolization of the arterial compartment to reduce the pressure in the venous compartment, what is the difference acceptable to will proceed the embolization through the venous compartment?
I analyzed rupture malformation, and in 80% I see stenosis of draining vein. And I think this cause of rupture of malformation. And in a transvenous approach is same, but after close of venous system, possible rupture of malformation. And the first step is disconnection of arteriovenous shunt. And pressure of venous system is a degrees of pressure. So we look pressure arterial and venous after transarterially occlusion of fistulous part of malformation. We look pressure in venous system, and 2/3 pressure go down, possible close of malformation. It's ideal. It's not absolutely in all patient and all situation, but it's ideal for transvenous embolization.
And you perform this kind of embolization only if you have only one venous drainage?
Venous drainage very difficult in malformation. It's I don't close off all venous system. So target for embolization, transvenous occlusion of and embolization, retrograde embolization malformation, it's venous system in nidus of AVM.
Okay, thank you, Doctor. Luis, you have another question?
Another question for Professor Hudak. I see you put the patient after embolization in hypotension. How many times? One with 24 hours? No, the question is, because I have one study about long time of the autoregulation of the brain, and when you put the patient with the hypotension, you have three types of response. One is going out, going down. It's very difficult. Yeah. It's very difficult to see. How many times and the level of hypotension?
So hypotension very important in a very short time after operation. But we quick close of malformation and venous system, and we see quick change of hemodynamic. And this time is very danger for rupture. And in my clinic, 24-36 hours in deep narcosis and hypotension. It's depend from malformation size. This depend, so transarterial transvenous approach is not simple procedure. It's very difficult. I think it depends from malformation size, localization, and now we start this carotideo-femoral shunt. This shunt system work 3-5 days, and this decrease pressure in arterial system for adaptation of changing of hemodynamics.
Me gustaría hacer una pregunta en español y luego me la traducís porque yo no soy capaz de decirlo en inglés bien. Él ha presentado algún caso en el que ha habido, el Torudar, ha presentado algún caso en el que ha tenido una hemorragia después de hacer esto. Es evidente que no en todos los casos va bien, puede haber una hemorragia. ¿Qué haría él o qué pensaría él, qué hizo mal en ese momento o qué no haría en ese caso en el que se produjo la hemorragia? O sea, ¿por qué se produjo la hemorragia? ¿Por qué piensa él que se produjo? ¿Qué no haría o qué no hubiera hecho? Si lo hiciera ahora, ¿qué no haría para prevenir esa hemorragia? ¿Y qué signos piensa él que puede haber en una arteriografía previa para pensar que puede haber una hemorragia?
Professor Durack, the question is, in that case where you presented that had a hemorrhage, what do you think went wrong? Why do you think the hemorrhage was produced, and what prognostic signs could foretell that there was going to be a
this
hemorrhage?
Is perioperative complication, and I think it's liquid polymer pressure. It's cause of bleeding. So it's not only after operation we look complication of rupture of malformation. It's possible procedure during operation, and possible rupture malformation and patient asymptomatic. So we see. I work with onyx and squid, and we look extravasation of onyx without bleeding. So it's not ideal material for embolism. And the next very big problem is material is adhesive. It's no all now. So it's possible rupture after removing of microcatheter. Now we have detachable microcatheter, but this is not good technique for embolization.
In the West, a lot of talking about Aruba every time we have an AVM session. I would love to ask all our panelists in Japan or here in Europe, did you see any change, or did you change anything in what you do in terms of endovascular interventional embolization of AVMs before, after Aruba? Did you change anything in your practice because of the trial, or that was just a smoke and not at all?
I think Aruba is very useful, but this is step one forward and two back. We have problem. We have malformation. It's pathology. It's danger pathology, and we have young people with this pathology. We have a patient with bleeding, and Aruba is stop malformation treatment and stop progress. Is bad, I think, for treatment AVM. And I think we thinking what possible do for good result of treatment of AVM malformation. So it's my opinion. So Aruba, it's good malformation, treatment malformation, it's not. We remember what happened with aneurysm. It's after ISAT study, yes?
But the ISAT was comparing two treatments.
Our colleagues
neurologists are going to say, we hear this every single time.
I remember treatment of AVM 20 years ago, and now it's very big difference.
I think it's the same thing which has happened to AVM as we have seen with sample trial, right? Because you're comparing the natural history with the possible morbidity of the procedure. So you are not standardizing the procedure, actually, right? So there are not single procedures that you are analyzing. So there are many variations in the approach of management of AVM, number one. There are many materials which are used for the AVM. There are different concepts which are being followed. So you can't put all those things in one basket and compare with the natural history. So yeah. So I think in our practice, Aruba has not made any change actually. Yeah.
For me, very important progress. So it's, I think, very big difference. It's open operation and endovascular operation of treatment of, for example, malformation. It's the resection of brain or it's normalization of microcirculation. So now we have good technique, very good DSA machine, very good quality. We have new material, new catheter. So I think it's very good in future possible complication with treatment malformation decrease it.
No, I think Aruba has changed a little the field because for the neurologists, our point of view, my personal point of view is that maybe we can do something in some. We need to treat only the symptomatic malformation. I think is the major message for me, because if you are maybe we are treating some patients that they need the treatment.
Do you think the AVM evolution?
Yes, but the problem is probably the problems of the Aruba is that there are many places, many different approaches. This is the problem is difficult to use in general. But maybe we should be more careful in the management of this patient.
What do you think about quality of life of young patient with malformation, with epilepsy? So I know possible patient don't have neurological deficit, have possible headache and epilepsy or possible without. But the patient know about this malformation and would like normal life in future. It's a big problem.
I mean, I think it's an illusion to think that Aruba didn't change. I mean, Aruba is maybe the best thing that happened to AVM and to us because it raised the standards. Before that, I think the approach of just thinking that what we have today is enough, it's clearly not enough. Unfortunately, we may be in some centers, but overall, we didn't do very well in this trial, and you can argue that the centers that chose to participate, for whatever reason, they were not prepared enough to deliver during the trial what we thought was true. And whenever a trial like this is, and the next session is going to talk about strokes, and stroke shows today the level of maturity that the field has arrived, that the randomized trials show that our surgery is done better than the medical treatment, for example. But it's not possible to be sure of that if we're not able to prove in a randomized or in a trial. And I think that I'm of course upset with Aruba results because it shows us the truth of what we are today and how consistent we cannot be. You go to a session, you ask any of us here how you should treat this lesion, I guarantee that the people would have 5 different opinions. So Aruba shows us the need for standardization to understand how radiosurgery, open surgery, and embolization play a role on AVM and how we make the choices. And I think that this will be very good down the road. It's going to be bad for a few years, but it will force us to get better. I think that's the message for me on that.
It's time to a coffee break, and then the coffee will continue with stroke and basal stenosis.
Sí, sí, normal.